So we're going to have a stroke.
Looks like people are still joining. I'll give them just another minute and then I'll go ahead and explain this slide here and then I'll kick it over to you.
Okay, thank you. And if there's any technical problems, of course, let me know.
Yeah, absolutely. All right, everyone, for the sake of time, we will go ahead and get started. Welcome to the Savaro Grand Rounds series. I just wanted to outline this housekeeping slide before we let Dr. Brummett jump into the presentation. With that, this slide outlines how to obtain CME credit. So there are 3 ways to submit attendance for CME credit. You text the attendance code to the number outlined here, and that code is 55176 for today's session. You can also search for Cloud CME in the mobile app and download that app and then log in using your email address and password and enter the attendance code there. And then there's also an online version and attendee portal where you can sign in to claim your credit there. Of note, since this presentation offers AVIM MOC credits, to gain those credits, you must have your full profile completed, and this is only a one-time requirement with your information before submitting the attendance to receive that MOC credit going forward. So when you complete the profile, all you'll need to enter is your birth, month, and day. Click yes, and then select the ABIM and enter your diploma ID. So with that, we'll jump into the presentation, but as a reminder, the attendance code is 55176 for today's session. And thank you all for joining.
Okay, so it's nice to speak to you guys. So we're going to talk today about stroke imaging, and we're really going to hit hard CT perfusion. So as far as disclosures, I do have an affiliation with Savaro. As far as goals of the talk or outline, we're going to briefly talk about the historical treatment concepts and understand the evolution of the imaging and stroke treatment relationship. Hopefully by the end of the lecture, you'll understand that advanced stroke imaging and advanced stroke treatment absolutely go together. We're going to talk about the basics of stroke imaging briefly, and we're going to talk about the CT stroke protocol. The CT perfusion exam is, of course, one component of that protocol. We're going to talk about the basics of stroke brain physiology, and then we're going to try to relate that or tie it to the CT perfusion images. We're going to talk quite a bit about CT perfusion concepts so that you guys can better interpret the examination. And that's kind of the main part of the lecture, in my opinion. Another thing is I want to be vendor neutral. There are many vendors that can get the job done. With that in mind, most of the time when people give these lectures, they typically stick to one vendor. I'm going to present you guys images from 7 different vendors. I'm also going to show you images from old software and new software because I want you to be comfortable being able to read across the different vendors. Finally, and this is not a classic CME goal, it's more of a me goal, but I want you guys to have a good time and I don't want you to get a headache from this. Kind of tongue in cheek, this information can be rather intense. So I am going to try to keep it as simple as possible so we learn the concepts needed to read the exam. As far as goals of stroke imaging, I think everybody knows it. We're going to hit it again. Of course, you want to try to pick up an intracranial hemorrhage. You would like, if possible, to identify the stroke. You want to identify the LVO. And you want to identify the penumbra and core, which again is principal to CT perfusion imaging. You want to exclude stroke mimics such as tumor. And I think you should get prognostic information. I'll tell you that's a little bit controversial. The CT perfusion study is actually showing the brain at a snapshot in time while the patient's on the table. Having said that, I think, and hopefully I will convince you, that you can actually determine how the patient might perform should you happen to restore blood flow to the brain. And of course, you want to get the information out very fast. Now, kind of going back in time, this is the treatment model that existed when I came out of my training, and I call it a time as brain model. So as far as imaging, advanced imaging, all they used was a non-contrast CT, and primarily they were looking for hemorrhage. So because of the limits of imaging, you guys were limited in how you could treat patients. So if somebody had an unknown time of stroke onset, such as a wake-up stroke, which is nearly 30% of the population, they were not eligible for thrombolysis. Less than 3 hours, thanks to the NINDS trial, if they don't have a hemorrhage, you can give them IV alteplase. Less than 6 hours, last known well, thanks to the PROACT 2 trial in 1999, you can give them intraarterial thrombolysis, which includes either medication or mechanical thrombectomy. Unfortunately, at this point in time, after 6 hours, unless they had a posterior circulation stroke, where the mortality rate is near 90%, you really couldn't do much. They would allow you to treat posterior circulation strokes because you basically had nothing to lose. Now, we have evolved nicely from a time as brain concept to a time as tissue concept, or as I call it, physiology as brain concept. So now you can give IV thrombolytics up to 4.5 hours. And that, by the way, does not require advanced imaging. You just have to make sure there's no hemorrhage from an imaging standpoint. You can now treat wake-up strokes, provided that advanced imaging, such as CT perfusion, indicates the patient can benefit from the treatment. You can still give intraarterial thrombolysis up to 6 hours. And what's really cool now, with an LVO, if the advanced imaging indicates the patient can benefit from treatment, you can do mechanical thrombectomy. Now, this is a slide that basically incorporates nearly 30 years of what I call landmark studies that help determine the treatment paradigms. One thing I want you to appreciate is that the red studies here, these are the studies that I think include more advanced imaging. So it's either going to be perfusion imaging, or it's going to be mismatch imaging, where you look at the total stroke volume and the core volume, or a combination of both. So all the newer studies incorporate this more advanced imaging. Also, interestingly, 2018 was a huge year with these 3 trials, the DAWN, the DIFFUSE 3, and the WAKE UP. And 2018 is when they actually expanded the stroke windows to up to 24 hours. That's just all the authors of those articles and the articles themselves. So let's talk about the stroke protocol. The stroke protocol, the one that I advocate, includes a non-contrast CT. If there's no hemorrhage, of course, 85% of people do not have a hemorrhage with a stroke. You go on to CTP, and then you do the CT angiogram of the head and neck. If they have hemorrhage, such as a subarachnoid hemorrhage, you maybe stop. Probably subarachnoid hemorrhage, non-traumatic, you don't stop. You go to the CTA to look for the source of the hemorrhage. Now, I believe the results should be given to you guys for a non-contrast CT easily within 35 minutes. You'll see people talk about 45 minutes. And I just tell you personally, I think that's ridiculous. The stroke is supposed to be cleaned. The CT imaging is supposed to be completed within 25 minutes. It does not take 20 minutes to read a non-contrast CT. It takes about 2 minutes. As far as the door to CT angiogram and CT perfusion results, I think you guys should have those within 45 minutes. So let's talk real quick about the various different components of the protocol and kind of get a setup of how we're going to take, which is really built-in internal control. You can compare the normal side of the brain to the abnormal side of the brain. So in this case, we have a CT of the head. You see the insular ribbon right here, which is white. You see the cortex here more posteriorly, which is white. And you see the white matter, which is darker. You see a very nice delineation between the white matter and the cortex, or gray matter. Now look at the disease side. First, if you step back, this entire side of the brain on the left side is darker. And if you look at the difference between the cortex, the gray matter, and the white matter, it's gone. So this is a stroke with a non-contrast CT. In addition, for this case, we kind of have a bonus. You see this white thing right here? That's the thrombus with the M1 segment, so that's a dense MCA. This is the CT perfusion. We're going to hit this really hard, so I'll just get straight to the point here. The normal side here has the reds and greens. The abnormal side is very dark. It's very easy to see the stroke with a CT perfusion exam. Here's a CT angiogram study. This is a thick MIP. And so I'm going to give you a little trick. If you're going to want to see if there's an LVO, go to the thick MIPs right away. The thins are wonderful. They're really good for a clinician aneurysm, but the thick MIP will give you what you need most of the time. So in this case, the normal side, the M1 segment here is the horizontal. It's a pacified. The M2 goes vertical. And on the abnormal side, of course, we have a thrombus right here in the proximal M1. This is an example of a CT angiogram of the neck. This is a MIP image sagittal projection. You have the common carotid artery coming up. It splits into the ECA. Then posteriorly, you see the ICA. You see the calcification for plaque. And in this case, we have normal caliber. It's very thin here. That's called a string sign, and that's normal caliber. All this information is provided very quickly with the CT stroke protocol. So there are other people that will do it other ways. And this is a slide I grabbed from a lecture from Harvard. WashU did the same thing. Some places have MR scanners and MRI personnel available 24/7. Most places don't. So sometimes in those places, they will do the CT, do the CTA, they'll pull them off the CT scanner and put them on the magnet and then complete the study. That's perfectly fine. So there's more ways, more than one way to do it. I'm just going to talk about the CT way today. Now, stroke mimics. Here we have the CT of the head. You have the normal side over here. You have the gray matter here, the white matter here, and of course you have this dark thing here. So this involves the posterior left frontal lobe. It's involving the cortex and the white matter. This is an excellent look for a stroke. The problem with this is that the CT perfusion study did not show decreased perfusion here. The perfusion was actually increased. So I talked to the neurologist. We did not give him TPA. We took him over to MRI. So this is our diffusion weighted sequence. If this was a stroke, this should be extremely white. It is not. So this is not a stroke. The FLAIR sequence shows a heterogeneous mass with a solid component anteriorly, a necrotic or cystic component posteriorly, and a small amount of vasogenic edema. After contrast enhancement, of course, the solid component enhances, and then we have peripheral enhancement around the more cystic component. So in this case, the CT perfusion study helped us avoid giving thrombolytics to somebody with a brain tumor. Now, let me make one quick statement about AI or computer-aided detection. It's kind of the buzzword now throughout society that exists in medicine. You've probably heard it's supposed to replace the radiologist pretty soon. It hasn't yet, thank goodness. So here's, I'm just going to be a caution. So in this case, the machine thinks there's a hemorrhage here. It's because you see the white here along the posterior falx. See these two images? The problem, this is not hemorrhage. This is called the straight sinus. So in this circumstance, everything that's red is suspected hemorrhage. So you see the red back here behind the cerebellum and the occipital lobe. Given the configuration, this could be a subdural or an epidural hematoma. The problem in this case is that this is actually the transverse sinus. So my point here is I want you to read the images yourself, make your own decisions, and then use AI to confirm your opinion. That principle also exists when reviewing the CT perfusion studies. They make the summary maps. The summary maps are great. Sometimes the summary maps can be non-diagnostic, but you can still pull information out of the individual perfusion parameter maps. That's going to be a common theme throughout this discussion. Another thing I want to warn you is that CT involves radiation, and you have to do it correctly. So here we have the sagittal image. And by the way, this image does not directly apply to this patient. This is just for example purposes. But we have the sagittal image. The colored part here is the perfusion port of the brain. This is 4 centimeters. If I was to put a ruler up to this poor lady's head where she's had her skin burned off, this is 4 centimeters. So my point is here, be very careful, make sure that the technologist and everyone knows what they're doing. Now, as far as limitations of CT perfusion, I think it's awesome, but it does have limitations. One of the limitations is really small strokes. So here's an example. You have a diffusion weighted image here. You have the thalamus, which is white. This is restricted diffusion. This is a stroke, clearly. The CT perfusion study on the same patient does not show the stroke. CT perfusion can also miss strokes in the posterior fossa due to the beam hardening artifact from the occipital bone and the skull base, and it'll also miss strokes which are outside the field of coverage. Now, let me talk real quick about field of coverage. So there's 4 basic flavors now. There's 4 centimeters of coverage, 8 centimeters of coverage, 12 centimeters of coverage, or 16. I personally think you have to have 8 centimeters or better to be doing diagnostic imaging, but at 4 centimeters of coverage has a sensitivity for stroke detection of 70%. It has a sensitivity of 80%. 12 centimeters has a sensitivity of 90%, and 16 centimeters, which is whole brain coverage, has a sensitivity of 95%. For reference, MRI has a sensitivity of 99 to 100%. So CTP is awesome, but there are limitations. Another thing I want to warn you about, and maybe you've seen these, as I've said, there's multiple vendors, there's multiple articles as I've listed here, which have reading all these is the gist. First off, most of these studies pretty much prove that all these software vendors make a good product and they'll help you treat your patients. Having said that, the actual outputs, core size, penumbra volume, even mismatch can vary among the vendors. So my advice is to not apply the criteria from one vendor to another person's images. Use the vendor's recommendations when you interpret the exam. So know who the vendor is and what their software recommendations are before you read the study. Also, again, this is one more reason why I think you need to learn to read the individual perfusion maps and not just jump to the summary map. Now, brain physiology. Now, truthfully, you guys know this better than I do, but we're still going to talk about it. So here's an image of a brain. It's a modified image from a Gonzalez article. You have the ICA coming up. It splits into M1 and the ACA, and here's the clot, the dark thing. And of course, all the brain tissue behind it is the stroke. We have the core here in gray, and we have the penumbra in pink. Now, from a cellular level, of course, a penumbra cell, the sodium-potassium pump will fail due to lack of oxygen. Sodium accumulates, water rushes into the cell swells, you have cytotoxic edema. At this point, the cell can no longer carry an action potential, and it is basically not working. So the good news is with the penumbra cell, the cell membrane is still intact, the organelles are still intact, and if you restore flow, this cell can survive. Of course, the core infarct, things have gone horribly bad. Everything's progressed. The cell membrane breaks down, the organelles die, and if you restore flow to this cell, it will not come back. In fact, truthfully, since the blood-brain barrier has probably been disrupted, it probably has a higher incidence of hemorrhage. Now, let's talk about how we see that physiology with imaging. So again, we see the clot, we see the stroke, and here's just a illustration from something I did a long time ago that shows what a CT scan would look like just as far as drawing it out schematically. Here's the normal tissue on the right side. Remember, the brain is a perfect mirror structure. And then here's the affected tissue. The core infarct, the part that you cannot save, is displayed in red. It's more central in this case. And then the penumbra is the green. This is the tissue that can be saved. And then the oligemia, which is the tissue very much on the periphery and will probably make it no matter what you do, is yellow. Now, for purposes of demonstration and display, the vendors pretty much lump the penumbra and oligemia together. So you're going to basically see the core infarct, and then you're going to see the penumbra. Here's an example of that. So this is a Phillips image. It's a summary map. So in this case, the anterior frontal lobe, the posterior frontal lobe, and the parietal lobe are all penumbra. They're labeled in green. And the core infarct here is red. Now, if I was to look at this grossly, and we're going to do this a few times, I would call this a basic mismatch ratio of about 2 to 1. So this image is going to take the place of like an hour-long lecture, so kind of bear with me here. How they acquire the images, and this is a modification of an image I got of a Canon product. Anyway, so you place the patient in the scanner. The technologist will then select the scanner range. Again, you have 4 through 16 centimeters of coverage. It's typically centered around the basal ganglia because the deep gray structures are a central part of the brain, and because of their high metabolic rate and their small vessels, they are more prone to show stroke early. And then you start the injection. At first, there's no contrast in the brain. The brain picks up contrast, maximizes contrast, and then the veins pull the contrast out of the brain. What you get are time density curves, and these are important. So you have time on the x-axis, you have the CT value or Hounsfield value on the y-axis, and you get an arterial curve, a soft tissue curve, and a venous curve. Again, no contrast, contrast is picking up, maximum contrast, contrast decreases, no contrast. So now let's talk about the parameters and how they relate to what we just saw. First off, the CT perfusion study can be done as an absolute model technique, which is an older technique, or a deconvolution technique. The absolute model technique, you inject the patient really hard, like 8 to 10 cc's a second, and then you image and create the curve we just showed. The deconvolution technique, you do not have to inject the patient as hard. It's like 3 to 4 cc's a second. You acquire the curves, and then it applies math to produce the data. The deconvolution technique allows for recirculation, meaning the contrast will go to the brain, out of the brain, and then back up to the brain. The absolute slope model does not, and that's why you have to inject the patient so hard or so fast with the absolute slope model. Most everyone now uses deconvolution. The parameters can be evaluated as absolute values. So every parameter has a normal value for gray and white matter, or as relative values where you compare one side of the brain to the other side of the brain. There are multiple combinations of the parameters that can be used to determine core and penumbra. I'm going to show you cases where we use the different parameters to make these determinations. Now, as far as the parameters themselves, they're listed right here. So the mean transit time, or MTT, it is how long it takes for the blood to go across the brain. It's given in seconds. The cerebral blood flow, or CBF, is the rate of blood flow into the brain. The CBV is the volume of blood per brain tissue, cerebral blood flow, excuse me. That's given in mLs per 100 grams. The time to peak is just like it sounds. It's the time it takes for the brain to maximize enhancement. The time to max is the delay between the contrast arriving in the large arteries proximally and the brain tissue. Now, the time to peak and the Tmax are different parameters. You can see the definitions for yourself. The time to peak is a direct metric. It's often used with the absolute slope model, but you can also use it for deconvolution. And the Tmax is actually deconvolution or processed data metric. For the purpose of the learning, we're going to basically consider them the same things. I'm just telling you this because they're not the same things, but we're doing this on purpose so you guys can pick up the concepts needed to read the study. Now, more the kind of the physiology and what we're going to see. So of course you have the blood coming from the heart, goes up the neck, hits the brain, then goes into smaller vessels within the brain. The blood hits the capillaries where oxygen is exchanged, and then the venules pick it up and larger veins take it up and take it on out of the head, right? What we see on CT scan, again, we showed before, the contrast is no contrast. It picks up contrast, maximizes contrast, then contrast goes away. Here's that time density curve we talked about earlier. So now we've applied the parameters to the time density curve. And for me, guys, this is when I finally understood the concepts, when I actually saw this graphically like I'm going to show you. So we have seconds on the x-axis. We have the density value or Hounsfield value on the y-axis. And then we have no contrast here. Contrast picks up in the brain, it maximizes, and then it washes out. The mean transit time, how long it takes for the blood to cross the brain is displayed here. See this line? It's across the base of the bell-shaped curve. The time to max is here. It's the time from no contrast to maximum contrast. The CBF, how quickly the blood flows into the brain, is displayed by this black line right here. And see how in this case, which is we're going to consider normal, it's nearly vertical. And the CBV, or the cerebral blood volume, is displayed here in the purple. It's the area under the curve, okay? This is normal. I'll show you abnormal in a second. So real quick here, stepping back again, we have the normal brain here, and we have a brain here with the thrombus. Normal brain contrast and blood goes up to ICA, and then goes to the M1 and ACA, goes out to the brain tissue very easily. When a thrombus occurs, there's big trouble. So when a thrombus occurs, of course, the tissue is affected. We have our core infarct in this diagram as the maroon. We have the penumbra as the green. The brain compensates with autoregulation and collateralization and vasodilation. So basically, it'll shunt blood away from the occluded vessel to an open vessel. It'll then open up the capillary bed. This bed is not typically this distended, and pull brain into the affected tissue from an open artery. Now, just again, stepping back, if you were traveling blood cells from here in the normal one over to the M1 and M2s, this is a straight shot, very easy. This is not a straight shot. This system, the compensatory system, is not as efficient. And understanding that it's not as efficient is the whole key to understanding CT perfusion. So again, we talked about what happens. Vessels occluded, autoregulation, vasodilation, and collateralization. Now with penumbra, the mean transit time will increase a little bit. The Tmax will increase as well, as will the TTP. Remember, it's not as efficient of a system. The CBF, or the flow rate of blood cells into the brain tissue, will decrease. And the CBV is very interesting. So the brain compensates quite nicely with CB at first. At first, the CBV is actually increased, and then it begins to drop. When the CB is above normal, or slightly below normal, this tissue is still salvageable. This is still penumbra. With core infarct, these factors just continue to progress. So the MTT, the TTP, and the Tmax continue to get increased. The CBF, the flow rate, continues to decrease, and the CBV then decreases to the point where it's a critical value, and the brain cell will then die. That is core infarct. Here's that graph again. So again, we've occluded the vessel, we showed that earlier, and here is the normal slope. So see how the normal bell-shaped curve is very tall relative to width? This is what it looks like with a stroke, okay? The curve is now flattened. So what happens is the mean transit time, remember how long it takes the blood to cross the brain, has increased. It's this line here is longer than this line here in a normal bell-shaped curve. The Tmax has also increased. So this line here is longer than this line here. The CBF, or the flow rate, has decreased. This black line here is now not as upright as it was earlier. And the CBV, like we talked about, initially will increase, and then it just begins to drop with the stroke. Now, one more thing before we start taking cases. As you approach the maps, I want you to approach them kind of like I approach a VQ scan in nuclear medicine, okay? So here's normal here on top. We give them an agent, which shows up in nuke medicine. We have them breathe it in, we image them, and it takes up inside the lungs. Then we give them an agent, we pull out some blood, tag it with the nuclear medicine agent, put it back in the patient, image it when it goes to the lungs. This right lung here matches, on the ventilation, matches the perfusion exam. This is normal. The left lung here on the ventilation matches the perfusion. This is normal. Abnormal's down here. So here's the right lung. It actually has normal ventilation. But look at the perfusion. This part here, which is squared off, is not squared off. So that's a perfusion defect. Look at the left lung. This part here, which comes to a nice point, is truncated. So this is abnormal. So that's the way I kind of want you guys to approach the perfusion maps when we read the study. Now let's take some cases. So a couple caveats before we start. CTP can be used to look at seizures. It can be looked at vasculitis. You can look at tumors. We are just doing CTP for acute stroke cases. Also, the stroke protocol is actually between 2,000 and 9,000 images. We don't have time for that. I think down the road, Savaro is going to look into some formats we can actually take entire stroke cases, and it'd be awesome. But today, I'm going to select cases for you, select images for you, so we can get through cases fast. Now, I'll warn you, it's going to go pretty intense, pretty fast, but remember, repetition is the mother of learning, and we're going to try to take advantage of that principle. So let's start with a case. So this is a vital image or Vitria case. It's owned by Canon. It's old. It does not have a summary map. We're going to use a diffusion weighted image to see whether or not we read the exam correctly. So here's the parameter maps. Here's the MTT, here's the CBF, and here's the CBV. Now, when I don't have a summary map, even when I do have a summary map, I typically read the MTT first and compare it to the CBV before I do anything else. So in this case, let's look at the data. So this is the normal hemisphere, okay? Everything over here look at the color scale, is low MTT. So blue and green is lower. The red and the yellow is higher. So we know the stroke is right here at the anterior left frontal lobe. It's also back here at the left posterior frontal lobe, but much smaller. Now let's look at CBV. So in this case, the normal side of the brain is this blue, darker blue, lighter blue, and this over here, the green, is actually elevated. So we have the stroke here, the prolonged MTT, and the CBV is also elevated. That is penumbra. Same with this. Prolonged MTT, increased CBV, this is penumbra. So if we can restore blood flow. So this is a case where we thought we saw some clots at the M2 and M3 segments. So I went ahead and ran a catheter up and gave them intraarterial TPA, and this is a diffusion weight exam the next day. So again, this should be a stroke if it completed. Since we were able to open up the vessel, we were able to restore the blood. This person is perfectly fine there. This back here, I couldn't open up. This is core. By the way, the patient had no symptoms after we treated him. So this is what I mean by providing prognostic information. While this is a snapshot in time, we could also determine, in my opinion, that if we were successful in establishing flow to the patient, we could actually help the patient, as proven by this diffusion weighted image. Now, here's another one. This is an older Siemens image. So here's our non-contrast CT, and here is a stroke window, so it's very grainy, axial source images for the CT angiogram. One thing I want you to appreciate is it's very difficult to see a stroke sometimes in a non-contrast CT. It'll miss the stroke about 50% of the time. In this case, this left lateral ventricle is wider than this side, so we know there's some edema and mass effect. This should be where the stroke is located. On this image, again, it's very grainy, but kind of read through it and see what it's for. So this is the cortex, it's white on the normal side. Here's the white matter, it's dark, very well distinguished. Over here, it's just kind of one color. So this is where the stroke is. So here is a thick MIP. This is the normal side. This is the M1. Here's the abnormal side. Here's the M1. It cuts off because of a thrombus. Here are the perfusion images. So at this time, we don't have the metrics displayed. I just want you guys to look at the general colors and think about the concepts. So this is a CBF. This is a CBV. So the normal side, again, everything that is green and red in the cortex and light blue in the white matter is normal. The abnormal side, it is all dark purple. So this is all the part of the brain which is affected by the stroke. We have the anterior frontal lobe, of course, the posterior frontal lobe, and the parietal lobe. Now the CBV, again, the normal is going to be red and green and light blue, and abnormal is this purple. So this is severely reduced CBV. Now think about our VQ scan example. Where this defect is, severe decrease in CBV matches this. This will demonstrate the core infarct. Now back here where the stroke is, demonstrated by the dark blue, it's actually normal. So this would be the penumbra. So I have to ask you guys this. Would you treat this patient? My answer is a hard no. So the mismatch ratio is probably about 1.2 at best. This is not a good person to treat. Having said it, this one's got a story behind it. So this person came in from an outside institution with these images. The neurologist called me and said, hey, I'm loading him. I'll meet you in the reading room. He shows up in the reading room. I tell him exactly what I told you. This is a big old stroke. It's mostly core. I can't do anything. He then proceeds to tell me that, sorry, David, but I promised the family you would try. So like a good radiologist, I did what I was told. And so I helped a friend as well. But anyway, so here's the ICA. Here's the ACA, and the middle cerebral artery is completely out. So I worked like a dog with a penumbra. I got it open, actually. But despite getting it open, I didn't really help the patient. So this core infarct is demonstrated by the diffusion weighted image afterwards as the white part. So everything we predicted to be core infarct, irregardless if I open up the vessel, proved to be core infarct. Also, as you can tell, the edema has already increased. This ventricle now is even more narrow than it was earlier. So again, it gives you information. It also tells you how you can perform should you be successful in opening up the vessel. Now, this is an older Philips Portal product. It was designed by a brilliant neuroradiologist named Max Wintermark. He's truly one of the great ones in my profession. Anyway, so what he did is he looked at the different perfusion parameters individually and in combination and determined which ones were better at depicting where the stroke was and where the core was. What he determined is that a relative MTT, where that's increased by 145% or more, is decreased perfusion. So let's take his principles and apply it to his images. his image concept. So anyway, so here's the brain, right? Normal's over here on the right side. It's going to be all this yellow and orange, right? Abnormal, 145% or more, is going to be green through blue. So all of this is the affected hemisphere. This is a huge stroke, right NCA distribution involving the anterior and posterior frontal lobe. Now let's jump over here to the CBV. So again, what he determined was a CBV of 2 or less is core infarct. So in this display, everything that's dark blue to black is going to be core infarct. So look at this here. On this image, see the black here? This is supposed to be core infarct. Now, if you were to create a summary map in your head, which is what I want you to do, you would say, okay, we have a big stroke here, right? It's proven on the MTT. This part here, which has increased CBV compared to the other side, and certainly higher than 2. This part here and this part here will be penumbra. This will be the core infarct. Look at this image, same thing. This is going to be penumbra, where it's nice and green, and the dark here will be core infarct. Summary map shows that. So again, core infarct is red as predicted here. Core infarct is red as predicted here, and the penumbra is pictured here in the green. So we were able to determine what was going to happen without the need for a summary map. Having said that, when the summary map is good, it confirms what you're saying. It just makes you more confident in what you're doing. Now, this is a case I got from Rapid. Rapid is truly one of the big dogs. The Dawn and the Diffuse 3 trial both used Rapid software to process the images for the study. So in this case, we'll just cut to the chase. You see the dark part here at the parietal lobe and posterior frontal lobe. This is edema. This is hypodense. This is where the stroke is located. Now, just for your benefit, they also provide now with their new software a hypodensity map, which is displayed here in the blue. This is a CT angiogram on the patient. So let's look at the normal side first. All right, we have the ICA coming up. Here's our M1. Here's our M2s. We have really great collateral vessels here. On the affected side, you have the ICA coming up. You have a clot sitting here in the M1 segment, and then you have the collateral vessels out here. The collateral vessels here are not as dense and numerous as they are on the normal side. Hope you guys can appreciate that. So here's their perfusion images. Again, let's go to MTT. So everything that's going to be abnormal is going to be yellow to red. And so we know this is the affected hemisphere, which is predicted on the CT angiogram. And now let's look at the Tmax. So everything above 6, so everything greater than the green is going to be abnormal. So this is affected as well. In this case, the really bad is the really dark red. Now let's jump over to the CBF and the CBV. CBV, again, which is what I kind of prefer when I look at these images, shows this to be the core right here at the deep white matter. See how it's darker blue compared to the contralateral side? And also back here, there's also core infarct back here. There's a little bit of penumbra here. Same thing with the CBF. In this case, this is all severely reduced. This is reduced. This is so. If we look at this, we'd expect this entire hemisphere to be affected. We expect most of the infarct part to be core infarct, and there'd be some penumbra posteriorly. That's what their perfusion maps show. So they don't overlay maps. They have separate maps. So they use an absolute Tmax of greater than 6 for their decreased perfusion, like we talked about. It's displayed in green. And then their core is a relative CBF of less than 30% compared to the normal hemisphere, displayed in the magenta. Now, they also give you a core infarct volume, which is 66 in this case, and a mismatch ratio. Now, they say thrombectomy may be indicated, and that's because when you look at the diffuse 3 data, if you have a mismatch ratio of greater than 1.8, and you have a core value of the core infarct less than 70, they actually could be a treatable patient. What's kind of interesting is the Dawn trial has a maximum core value with relative CBF of less than above 50 you shouldn't be treating. So the two studies kind of contradict each other there. And that's be an interesting one to find out how you guys would approach that. They have a hyperperfusion map, as do the other vendors. I'm not going to go over the hyperperfusion map with everybody, but let me describe to you what it does, because it is pretty neat. They compare the Tmax of 10 to the Tmax of greater than 6 and establish a ratio. That ratio will help determine how good the collateral flow is. So the ratio here is 0.7. Everything above 0.4 is considered poor collateral flow. So think about all the data we've gotten from this study, which took about 10 to 12 minutes to acquire. We determined there's no hemorrhage. We saw the stroke. We then classified the stroke for core and penumbra, including volume and mismatch ratio. We saw the thrombus in the MC in the M1 segment, and we also established collateral flow. Just a tremendous amount of data. They gave me another case. Remember I told you posterior circulation strokes can be a challenge? Well, they gave me a case to prove to me and to you that they actually can do that. So in this case, we have a coronal image. It's kind of oblique. Here is the basilar artery coming up, and then it just stops. So there's a thrombus sitting right there. They have what's called a heat map, which tells you their confidence level that there's a thrombus there. And this thing is orange, which means they know there's a thrombus there. Here's the perfusion images. So let's just go to the Tmax. Everything above 6 is going to be in the orange to red section. So we know there's decreased perfusion of the brainstem and the right cerebellar hemisphere. You guys seeing that? And then look at the CBF and CBV. Comparing the affected side to the unaffected side, they're almost the same. So without the summary map, we would anticipate this to be pretty much all penumbra. It's precisely what the summary map says. You got it? So the green shows all the tissue, which is, of course, hypoperfused, and there is no magenta, so there is no core infarct here. So you have somebody with nothing but penumbra, and you have a basilar artery thrombus. This person needs to be treated. Viz. So Viz AI, it's a great one. It's another one of the big dogs along with Rapid. I used them for a couple of years. They're great. Their claim to fame, among other things, is that they're less susceptible to motion artifact, and anecdotally, I totally agree with them. Unfortunately, the images I have from them are not as good as I got from other people, and that's because the rep's a very nice person. We just kind of miscommunicated. I kept asking for images, and she kept referring me to the product brochure. So here we go. So here's the Tmax, right? Everything above 6 is abnormal. So everything in the red and orange is abnormal, clearly seen. And here's the CBF and CBV. You can see the dark part here does not match the contralateral side. So we would expect this to all be involved with more of the core infarct in the middle and the outside, outside here, this should be penumbra. They have a very nice summary map that displays just that. They use an absolute value of greater than 6 seconds, just like Rapid, so it's displayed here in green. They use a relative CBF of less than 30 to show core, showed here in red, just like Rapid, and they also give you a mismatch ratio. And here's just another viz. Here's just the summary map, just to show you. Again, Tmax 6, this is affected tissue. RBF less than 30, this is core, mismatch ratio 1.8. What's kind of cool is they have this, and Rapid does as well, and maybe the other vendors have an option to look at images on the phone. I don't know if you guys have done this, but they're outstanding. I would, I don't dictate reports off reading off images off the phone. However, I have been on the road. I've been contacted by folks to look at images on my phone, and I can easily make the diagnosis. It's a really nice option. Now, I showed you the old Philips. This is the new Philips. So there's a lot of images that Philips gave me. In the interest of time, we're just going to zero in on a couple of key ones. First off, I want you to appreciate the CT head. Here's the dense MCA, right? See how dark, how white it is here, the M1 segment. And let's jump up here to where the lateral ventricles are. So the normal side first, right? We'd like to look at normal first and compare it to abnormal. Here's the cortex. It's shown here in white. The white matter here is darker, and you have a nice distinction between the two. On the affected side, you cannot distinguish the white matter and the gray matter here. It's all just dark. You have an island of probably normal brain, and then you have another island back here of stroke. CT angiogram is great. This one's wide open on the right side. They have an occluded M1, just like shown on the dense MCA sign. And their summary maps are really, really pretty. So they have MTT given, they have Tmax, they have CBV, and now they have CBF. So let's jump up to that one we looked at with the lateral ventricles, again, just to preserve time. So MTT, normal is going to be down here in the green and yellow. Abnormal is going to be in the blue and dark green. So we know this is the affected hemisphere. This is supported by the Tmax. Again, everything greater than 6 is going to be in the green to blue. And let's go here to the CBV. So the CBV, this side here, the left frontal lobe more posteriorly, matches the unaffected side. So this tissue is going to be penumbra. This tissue here is very dark. It's certainly less than 2. This is going to be the core infarct. So again, if we did the summary map, this whole thing would be the involved hemisphere. This part will be penumbra. This part will be core infarct. There we go. This is that slice right here. So they show exactly what we need to see with their summary map. What's kind of interesting is, as opposed to Rapid and Rapid AI and Viz, which uses a relative CBF of less than 30% to show the core infarct, they use a relative CBF of less than CBV of less than 30%. So again, they're using a different parameter than the other vendors, which is perfectly fine. But it just shows you how things can vary and that you can use different parameters to get the information you need. Now, this is a newer Canon. I showed the old one, the new one. The images I think are just really, really pretty. This is the MTT. Here's the T-Max. You can clearly, we're going to take it a little quicker here. So normal is going to be in the blue and green, right? Abnormal is red. It's very conspicuous where the stroke is. Let's look at their CBV. In this case, this cortex here in the affected part of the brain matches the other side. This cortex matches the other side, same back here. The core infarct, if I was to predict, is going to be in the deep white matter, which is really dark blue, which is different the other side, and also back here. This is their summary map. It's precisely what it shows. So the red, I call it dark orange, they call it red, is the core infarct, and the real orange is the penumbra. Now, what's rather interesting is the other companies used a T-max of 6 seconds to determine the tissue which is at risk. Vitrea, what they use is a T-max of 2.2 seconds. Quite a bit different. The reason is they actually don't look at absolute T-max, they look at relative T-max. So when the T-max is greater than 2.2 seconds from the contralateral hemisphere, they flag that as decreased perfusion. They also use a relative CBV, not CBF, of 40% as their cutoff for core infarct. So they do it different. Also, just an extra add-on, they also add the base theory of probability, which is a theory that existed or was promoted in the 1700s to apply to their software because they think it increases their accuracy. I'll tell you, they are very good. There was an article that compared them directly to Rapid. Both vendors came out great, but definitely Vitrea did just as well as Rapid, I think. They also show really pretty 3D images. So, Brainomix, if you guys have heard of that, according to the vendor, they're the #1 CT perfusion company in Europe. They only were FDA approved in 2023. One of their co-founders actually helped with the Aspects trial, so they have really good non-contrast CT stuff, I'm told. But this is their perfusion exam. We've got the MTT here, right? Everything's going to be elevated. It's going to be green and red, so we know we're affected here at the anterior and the posterior frontal lobe. The T-max also supports that. It's worse here in the frontal lobe. And let's look at their CBV and CBF. Again, normal over here. This side is increased compared to the contralateral side. So this is increased CBV in affected tissue. So we're going to expect this to be penumbra, right? And then this dark part here, which is the opposite of this side, this is going to be our core infarct. This is supported in both the CBV and the CBF map. Here's their summary. Again, this entire hemisphere is involved. The core is anterior here, and it's also here central, right next to the basal ganglia. They give, of course, a mismatch ratio like everybody else, and they also give a hypoperfusion index as well. Now, I told you earlier, I think I told you, CT, yes, I did. CT perfusion does have a hard time with really small strokes, such as lacunar infarcts or basal ganglia strokes. So one of the things they claim is that they're better at picking up these small strokes than some of the other competitors. To show me that and to show you that, they gave me a case that shows a stroke at the basal ganglia. So in this case, you have increased MTT at the putamen, and you have increased Tmax at the putamen. Now, their CBF, relative CBF, clearly down here. So we think there's going to be a stroke here involving the putamen, but it's going to be pretty much all core infarct according to these two maps when you compare. That's exactly what their summary shows. So in this case, the red, of course, is the stroke, and it's pretty much all core infarct. So TerraRecon. TerraRecon is a great company. They make incredible CT angiogram products. I recently took a cardiac CTA course sponsored by the American College of Radiology. They had us working on workstations. All the workstations were TerraRecon. So they do really good work. So anyway, the case they sent me here, here's a brain. The M1 on the left is wide open. The M1 on the right is occluded thanks to thrombus. And here's their maps. The mean transit time map, everything that's green and red is abnormal. So this is the abnormal hemisphere involving the right frontal lobe anteriorly and posteriorly, as well as the caudate nucleus and the basal ganglia. You guys see that? This is their Tmax map. It shows the same thing. I actually like to display the MTT better with them than the Tmax. Here's their CBF map. So in this case, again, the abnormal side where it's really dark here, it's not dark here. So this is severely reduced and severely reduced back here. So this should be core infarct here centrally, which is deeper, including at the caudate nucleus. And this part here will probably be more penumbra. That's just a composite display of the same data. And here's their summary map. So it does show it. Truthfully, I don't like the summary map display. I'm not as comfortable as I am with the other ones. And it's probably more of a me problem than a them problem. But having said it, in this case, I would probably rely more on the individual perfusion maps than I would their summary map. With that in mind, let me show you one final case that does not have a summary map. It's a TerraRecon case. So in this case, we're looking at the MTT, right? MTT is elevated where it's red and yellow. So there's decreased perfusion. And let's jump over the CBV. So in this case, guys, think about it. The cortex here matches the cortex here. So this will be penumbra. The dark part here is going to be your core infarct. So if I was just to read this grossly without a summary map, I'd say there's a right MCA distribution stroke. It's large. And that the mismatch ratio is about 2 to 1 or 3 to 1. So here's the deal. CTP is great, I think. I think it's really helped treat patients. There's still a few people out there who haven't totally bought into the process. When I first gave this lecture 20 years ago, that's probably the majority of the room. I hope that the people I'm speaking to today, it's the minority. Would you please help me encourage people to use this technology? I truly think it's for the patient's benefit. And finally, you can't talk about stroke without talking a little about MRI. So since we don't have much time, I've condensed it into 2 slides. The first one is who's your best friend when it comes to picking up a stroke with MR. You have a T2 weighted sequence, which is good for picking up edema. It showed white, but also scarring or gliosis shows up white, and so do tumors. A flare is a little bit better. They suppress the CSF, so it's dark. So the T2 increase actually is more apparent in flare. So flare is a better friend. A very good friend is the DWI. So restricted diffusion, of course, will show up as white because the protons aren't moving. And so, but the thing about DWI, the reason it's not your best friend is because DWI is actually a T2 weighted sequence. So you can have this thing called T2 shine through. So you think it's a stroke, but it's not. So that's why ADC map is your best friend. This is a direct measurement map. This is actually a constructed map mathematically with computers. So in this case, restricted diffusion shows up dark. So if you have bright on DWI and dark on ADC, you can be very confident this is truly restricted diffusion. Now your flaky friend is AI. So in this case, AI colored it magenta for us. I don't think it was really necessary, but there it is. The problem is you can get false positives and false negatives. So in this case, let's look at the ADC. The ADC at the right cerebellar hemisphere is just like the left. The problem is the computer thinks this thing's a stroke. It is not. The computer made a mistake. You can also have false negatives. So again, this is bright here anterior to the frontal lobe on diffusion weighted imaging. It's dark on the ADC. This is clearly a stroke, but it does not cover magenta, so it missed it in this case. Again, my point is AI is awesome, but read the exam yourself and let AI help you. Don't let it read the exam for you. So real quick here, not all restricted diffusion is a stroke. Here we have the occipital lobe. It's bright on DWI. It's dark on ABC, clearly restricted diffusion. The problem is there is a capsule which has decreased signal on T2 at this lesion, and the thing also has nodular peripheral enhancement. This is a abscess. So not everything bright on diffusion is a stroke. Your abscess can be positive on DWI. Active MS plaques can be positive on DBI. Some TBI cases are positive. Encephalitis can be positive. And some tumors such as lymphoma and germinoma can have restricted diffusion. So when you see restricted diffusion, please keep it in the clinical context before you declare the patient definitely has a stroke. So in summary, we've come a long way on treating people and the whole treatment brain imaging paradigm. So CT stroke imaging is so much better than it used to be. We can show brain physiology during a stroke to help guide treatment. And now you should better understand, hopefully, how to interpret the examinations and understand what the data means. Also, finally, again, this is very important to me. I hope you guys had a good time. I certainly have appreciated presenting to you. It's been an honor. Thank you.
Thank you.
Thank you very much, Dr. Brummett. We can go ahead and conclude the webinar. We will send out transcripts and your presentation. If you're willing to share it, we can go ahead and share that with the attendees as well. Thank you all for joining. We will see you at our July webinar. Thank you so much.
Thank you very much.
Thank you.
Thank